Dr. Parikh, Dr. Ratima, should we start in another minute?
Dr. Parikh?
Yeah, we'll wait for 1 minute. 1 minute before we start.
I think we should. Yeah.
Dr. Ratima, would you like to introduce Dr. Parikh?
Dr. Purvish will do the people, Kashish.
Okay, I meant, would you like to introduce Dr. Parikh when he gives the welcome?
Yeah.
Kashish, you will share my slides, please.
Yes, sir. We'll do that, sir. Dr. Ratima, we can start whenever you're ready. So good evening, everyone. I welcome you. Oh, sorry, yeah, please go ahead. Please go ahead.
Yeah, good evening, everybody. So we are here from Dr. Lal Path Labs, Gene Evolved, the genetic division of Dr. Lal Path Labs. And we welcome all of you, all the attendees and all the participants, along with all the panelists with us. So Dr. Purvish Parikh, the moderator of this session, he needs no introduction, though. But I will just like to inform that Dr. Purvish is the chief advisor of MOC, and he is a precision and medical oncologist of Asian Institute of Oncology, Mumbai. So he is now chairing the session for personalized update on breast cancer. So I would just like to welcome Dr. Purvish, Dr. Shyam Aggarwal, Dr. Ajay Bapna, Dr. Shaheenah Dawood, Dr. Prashant Mehta, Dr. P.K. Jayachandran, Dr. Saurabh Kumar Mishra, Dr. Sevanti, Dr. Vinayak Maka, Dr. Akhil Kapoor, and Dr. Saurabh Bhattacharya. So welcome all of you, and over to Dr. Purvish now.
Yeah, thank you very much. I think we should not waste any further time. Let's get cracking. So Kashish, over to you to introduce the first speaker.
Thank you so much, sir. With great pleasure, I would like to introduce our first speaker, who's none other than Dr. Shaheenah Dawood, who's head of medical oncology at Dubai Medical College, United Arab Emirates. And she'll be talking on the topic, practical tips on clinical conditions and correlation with diagnosis in breast cancer. Over to you, ma'am.
Thank you very much for the kind introduction and the invitation to, I think, a very important meeting. And as I heard at the very beginning, at least it's not COVID related, because I think everyone's fed up of COVID right now. I'm just going to share my slides. My talk is actually on molecular profiling in breast cancer. And without further ado, let's get started. I think on a very, very important topic. These are my disclosures. So I think the first question that we need to ask ourselves is, why do we in fact want to profile patients who've got advanced tumors before we get into the realm of why we would do it in a patient who has breast cancer? So for the first reason is that identifying one important somatic mutation can in fact make a difference. And I love showing this slide. It was published more than a decade ago, looking at a patient who has metastatic melanoma, where you know that if you give chemotherapy, response rates would be at an abysmal 5%. But if you identify that one perfect target, such as a BRAF mutation, your response rates can go above 60%. We've also seen multiple clinical trials in multiple solid tumors that have shown that when you target a specific mutation appropriately, it can in fact be associated with a survival advantage over and above that related to chemotherapy. And you see three very important examples here. In lung cancer, we've seen that targeting at the EGFR EGFR mutation is associated with a survival advantage above that given chemotherapy. We've seen in melanoma, targeting the BRAF mutation with an agent such as vemurafenib is more important than giving something like dacarbazine. And of course, we've seen in patients with breast cancer, an example being those who have a BRCA mutation, using a PARP inhibitor such as olaparib or even talazoparib is associated with an improved progression-free survival compared to using physician choice of chemotherapy. So really a specific mutation and a specific target equals improved survival. We've also, in the last decade, seen the rapid adoption of tissue agnostic testing. This is the way we're going to think of our tissues in the future. We've had a number of agnostic tests that have recently been approved. We know MMR deficiency, if present, patients can receive immunotherapy. The presence of a TRK fusion, patients are eligible for drugs such as larotrectinib and entrectinib. We've seen recently approvals for RET fusion medications as well. We've seen also tumor mutational burden, RAS mutations, and NRG1 also rapidly becoming agnostic markers. So one target, one drug really equals all tumors. And this is just to show you the data. You've all seen this before. Patients who've got MMR deficient tumors given single agent pembrolizumab, which is an immune checkpoint inhibitor, is associated with a very nice overall response rate, a very nice waterfall plot. In patients who've got NTRK fusions, irrespective of the tumor type, when you give a drug such as larotrectinib or entrectinib, you can see overall response rates of above 75%, a very nice waterfall plot here as well. Last year, at the peak of COVID, we saw the FDA approve tumor mutational burden as being an agnostic marker, such that if you have a patient who's got a tumor mutational burden of more than 10, they would be eligible for single agent pembrolizumab. And this is based on the Keynote 158 trial. You can see overall patients who've had a tumor mutational burden of more than 10 can have an objective response rate of about 30% and a median duration of response that was not reached. But when you really go into the nitty gritty of the types of tumors that were actually enrolled in this trial, breast cancer doesn't seem to be one of them, and hardly any GI tumors as well. So I do think that this should be used with caution in the clinic, and I do not think it is for everyone, but still, when you have a patient with a high tumor mutational burden, you do discuss these cases in your MDT so that you can get an appropriate management plan. This year at ASCO, we saw NRG1 rapidly evolving to what I think will be an agnostic marker in the future. We know it comprises the presence of an NRG1 fusion comprises about 0.2% of all tumors, with breast cancer also being one of them. And we did see a very nice presentation that was presented by Shyam and colleagues at ASCO this year, looking at a very novel antibody known as Zenocutuzumab that was used in these patients with NRG1 fusion positive tumors, and you can see an overall response rate of about 29%. And these did include patients who had breast cancer, these bars that are highlighted here in pink. So why else do we profile tumors? We're not only trying to look for one target, we really are looking at those multiple targets, because one target and one drug will eventually lead to the development of resistance. One target and one drug does not inform on more potent targets. And we know that one target and one drug does not give you the whole picture. And that a prime example comes from lung cancer, where it's important to know all the information so that you can appropriately treat your patients. You need to know the presence of those mutations, the PD-L1 expression, TMB, and those other agnostic markers, because you want to be able to know the whole story before you develop a therapeutic plan. We also want to know if we can expand therapeutic implications of certain drugs. For example, immunotherapy drugs are not only relevant for patients with PD-L1 high expression, but also for patients with MSI high tumors, high tumor mutational burden, and those with interferon signatures. And ultimately, the reason why we're doing all this, the reason why we're profiling our patients, because we know that in the metastatic setting, We want to get that best therapy early, but we also know that with increasing lines of therapy, the progression free survival does tend to get shorter and shorter. And we would like to switch therapy early if it is not working, with the ultimate goal of trying to reduce that short intervals in terms of the decline in progression free survival. So we want to be able to give the best therapy early, to give the best, to be associated with the best prognostic impact for our patients. So now moving gears to those patients who've got metastatic breast cancer, really the question comes up, what is the role of profiling among patients with advanced breast cancer? Now, from a community oncologist perspective, when we're sitting in our clinics, we have a very simplistic view of seeing our patients with breast cancer. They either have triple negative breast cancer, where really the mainstay of therapy is chemotherapy, or they have hormone receptor positive breast cancer, where the mainstay of therapy is endocrine therapy, or they have HER2 positive breast cancer, where we know that anti-HER2 therapy is the backbone of any chemotherapy regimen that we're going to treat patients with HER2 positive breast cancer. But we know that we've really moved from these intrinsic subtypes to really expanding on patients with breast cancer, really looking at those various genomic drivers that can go beyond one subtype. For example, PIK3CA mutations are being looked at not only in ER positive tumors, but also in triple negative and HER2 positive tumors. So, really trying to look at the whole plethora of genomic drivers. We also know that the landscape or the genomic landscape of breast cancers can be very different from the primary tumor and the metastatic tumor. And this comes from a very nice paper that was published by Bertucci and colleagues way back in 2019 that looked at profiling patients who had metastatic breast cancers and profiling their matched primary tumor samples and really looking at those differences. And what they essentially showed was there are 9 driver genes that were more frequently mutated in ER positive, HER2 negative metastatic breast cancer, such as TP53, ESR1, GATA3, AKT1, NF1, and so on and so forth. There were also 18 amplicons that were more frequently observed in hormone receptor positive, HER2 negative metastatic breast cancer. Interestingly, when you looked at the tumor mutational burden, and you can see that over here, you can see that the tumor mutational burden is in fact higher in a patient who's got a metastatic tumor versus its counterpart in the primary tumor. So tumors do tend to evolve over time. And I always say that if you're going to profile your patient's tumor, if you have accessibility to the freshest metastatic tumor sample, that is what you should biopsy and that is what you should send for profiling. Now, we do use algorithms to be able to treat our patients in the clinic. And so, can the information derived from profiling, in fact, help us develop these treatment algorithms in the realm of advanced metastatic breast cancer? So, going back to that simple algorithm that we have as community oncologists, where we have bucketed our patients into either triple negative, hormone receptor positive, or HER2 positive patients, the problem with this simple schema is that number one, it assumes that a patient only has 3 biomarkers. It assumes that these biomarkers, in fact, stay static. And it assumes basically that the patient only has one pathway that's dominant, and that's what you're going to target. But in fact, that is not entirely true. So let's take the example of patients who've got triple negative breast cancer, where we know that there are multiple pathways that could be potentially targeted in these patients. You could target the DNA repair pathways, where platinums and PARP inhibitors become the mainstay. They may have an inflamed phenotype where immunotherapy is the mainstay of treatment. Those patients with androgen receptor overexpression, you can think about using drugs such as bicalutamide and enzalutamide. Targeting the PIK3CA pathway has been an interesting journey for patients with triple negative breast cancer. There was a lot of hope that AKT inhibitors would work in these patients. Some preliminary data presented at San Antonio last year was actually disappointing, but I think the story has yet to evolve. And of course, those agnostic markers such as HER2 mutations, NTRK fusions, RET alterations, and NRGI should be looked at in patients with triple negative breast cancer. Now, we've seen the results of a number of immune therapy trials in the realm of patients with triple negative breast cancer. We've seen the data from Impassion 130, which was a phase 3 clinical trial in the first line setting. Patients had to be triple negative, randomized to receive either nab-paclitaxel or nab-paclitaxel plus atezolizumab. And you can see in those patients who had PD-L1 positive disease, a very nice separation, the Kaplan-Meier curve, in terms of an improvement in overall survival, favoring the group of patients who are receiving immunotherapy plus chemotherapy. We then last year saw the results of the Keynote 355 trial, which looked at the combination of pembrolizumab and chemotherapy. And again, in those patients with a CPS score of more than or equal to 10, you can see a very nice improvement in progression-free survival in those patients who are getting immunotherapy plus chemotherapy. That was also associated with an improvement in response rates as well. Now, why do I think these two trials are important? Because it involves PD-L1 testing. And what you see here, this is results that comes from the Impassion 130, where they took the cohort of patients with triple negative breast cancer and they tested them for both SP142 as well as the 22C3 antibody at a CPS score of 10 for the 22C3 and a CP and a score of 1% for the SP142 to see if there were any differences. And what you essentially see here is that 36% of patients were positive for both antibodies, 10% of patients were positive for SP142 and negative for 22C3, and you had about 17% of patients who were negative for SP142 and positive for 22C3, suggesting that if you tested only for one antibody and it was negative, you would be potentially losing out on treating your patient with immunotherapy if they were positive for another antibody and you didn't test for that. So I think the key lesson that, at least for me, that I've learned from this is that you need to test for both antibodies up front so that you don't waste time and you have that information up front so you could be able to appropriately treat your patients. We've also seen that patients who have got a BRCA mutation, I did show this to you right at the very beginning, that if they're treated with a PARP inhibitor like olaparib or talazoparib, they do much better than when you give them a physician choice of chemotherapy in terms of improving progression-free survival. So one of the questions that keeps repeatedly coming up in a patient with triple negative breast cancer and PD-L1 positive disease in that first line setting, what are you going to use? Are you going to use a PARP inhibitor or are you going to use IO plus chemotherapy? And this is the basic algorithm that I tend to follow. Again, it's something that we've developed in our group at our institution, but it will vary from institution to institution depending on how you interpret the data that's out there. But if you have a patient who's got metastatic triple negative breast cancer and you test for PD-L1, if they're PD-L1 negative, you go on to test for those other biomarkers such as BRCA that can help you appropriately treat your patient. But if your patient is PD-L1 positive, and we then substratify to see whether they're in visceral crisis or not. If they're in visceral crisis, irrespective of the BRCA status, we tend to give IO plus chemotherapy. And then once they've progressed, we then look at that BRCA status and then treat appropriately based on whether patients have a BRCA positive disease or not. In patients who have no visceral crisis, we do then look at the BRCA status, and if patients are BRCA positive, we may consider giving a PARP or IO plus chemotherapy, and if they're BRCA negative, we do tend to give them IO plus chemotherapy upfront. So just to walk you through a case that actually of a patient who was profiled. This is a 55-year-old lady who was married in 2018. She was diagnosed with a locally advanced breast cancer. It was ERPR negative, HER2 positive, confirmed by FISH. This lady was treated at Memorial in the US. She received pre-op TCHP and had breast conserving surgery as well as axillary lymph node dissection, found to have residual disease, and then came to Dubai, at which point we gave her adjuvant radiation therapy, and as per the Catherine trial, 14 sessions of TDM1. Unfortunately, in 2020 September, less than a year from completion of a TDM1, she was found to have mediastinal lymph nodes, and you can see that from the PET CT scan over here. She's got her mediastinum lighting up over there, and we biopsied it, and the tissue was ERPR negative, and this time the disease was HER2 negative. Now the patient was and her family were very anxious, so they wanted to start off on something very quickly. So we started her on single agent eribulin, and at this point, we also sent her tissue for profiling as well as germline testing for BRCA. And what we essentially found was that she had MSI high disease with a CPS score for PDL1 being 10, a tumor mutational burden of 43, so very high TMB, probably because she has MSI high disease, as well as the fact that she had a PIK3CA mutation. So some of the questions that we asked in our MDT was, would we add immunotherapy at this point? Would we drop chemotherapy and continue immunotherapy on its own, continue chemo on its own, and then add immunotherapy upon progression, or do something different depending on her other biomarkers? The decision, at least from our MDT, was to in fact add immunotherapy and not drop the chemotherapy, and that's exactly what we did. She had no side effects associated with eribulin. We added pembrolizumab, and you can see she did actually very well by February. Um, um, in 2020, she had achieved a near complete response, and in April, she had achieved a complete response. She's actually due now in the summer to have another PET CT scan and continues to do very well. So let's shift gears a little bit. Another example now comes from patients who've got hormone receptor positive, HER2 negative disease. Again, not a simple algorithm to think about. There are different pathways that one needs to think about. You have patients who've got ESR1 mutations where we know aromatase inhibitors don't work as well. Patients who've got defective DNA repair pathways where we know PARP inhibitors and platinums may work better. And then, of course, those patients who've got mutations in the PIK3CA pathway where we know AKT inhibitors work. And then, of course, those agnostic markers such as HER2 mutations, NTRK fusions, RET alterations, NRG1, as well as the rapidly evolving tumor mutational burden, which should be considered in these patients as well. Now, what I find fascinating about patients who've got hormone receptor positive disease is that evolving endocrine resistance that happens in these patients when you give them endocrine therapy with or without a CDK4/6 inhibitor. And you can see that here from this pictorial diagram, that patients who are initially sensitive and then are given endocrine therapy, they will develop different mechanisms of endocrine resistance, such as the development of ESR1 mutations, alterations of the MYC pathway, alterations of the MAP kinase pathway, and of course those other pathways as well. The real question is, could evolutionary tracks in these different pathways in fact influence the choice of subsequent therapy? I think that will be the way that we're going to be looking at our patients in the future. At ASCO this year, there were some very interesting posters as well as oral presentations looking at novel SERDs, looking at novel endocrine therapy agents, and even looking at the novel antibody that targets NRG1 to overcome endocrine therapy resistance. Here on this slide, you see the genomic landscape of patients with ER positive metastatic breast cancer. And what's interesting about this is that, like I said before, somatic mutations in MBC really does differ from that of early stage breast cancer. But what's even more interesting is that the ApoBec signature seems to be an emerging phenomenon in these patients, because you can actually develop it over time, and is a treatment option for these patients who have refractory ER positive MBC, and using immunotherapy in these patients can actually work. And we've seen some very interesting anecdotal reports. We've seen the data that's been presented by Fabrice Andre looking at the use of alpelisib in patients who've got a PIK3CA mutation positive disease. The data for this comes from the SOLAR-1 trial, where patients with a PIK3CA mutation positive endocrine resistant positive disease randomized to receive either fulvestrant or fulvestrant plus alpelisib. You can see a very nice improvement in progression-free survival, but also at ESMO last year, we saw an improvement in both in overall survival both overall as well as in those patients who had lung and liver metastases. We've seen some nice results from the phase 2 Summit trial that has looked at the emerging biomarker of HER2 mutations in patients who've got endocrine resistant disease. We know about 8% of these patients will develop a HER2 mutation, and using a combination of neratinib and fulvestrant has been shown to work in these patients. You can see in these heavily pretreated group of patients who've got a HER2 mutation, it's associated with a clinical benefit rate of almost 47% and a progression-free survival of almost 5.4 months. So again, this is a simple algorithm that we tend to follow in our patients who've got hormone receptor positive disease. If you've got your endocrine sensitive patient up front, they'll get a CDK4/6 inhibitor plus an AI. We then test for PIK3CA. If they're mutant, they get alpelisib plus fulvestrant. If they're wild type, they'll get fulvestrant. And of course, in that third line setting, we'll look at those other various biomarkers. So just to rapidly go through some case studies of some patients with ER positive disease. This is actually a very interesting case. This is a 36-year-old lady who presented with a stage 4 de novo breast cancer, ER positive, HER2 negative, had extensive bone mets, liver mets, and lung mets. And we biopsied her, sent it for profiling, and concomitantly started her on a CDK4/6 inhibitor, GnRH analog, and an AI. And very interesting results. You find that she actually has an NTRK3 fusion that was detected, and the type of fusion was actually has not been reported before. She's got a PIK3CA mutation as well, and a tumor mutational burden of 9, and an androgen receptor expression of almost 95%. So some very interesting results. And like I said,
Shaheenah, sincere apologies, but we are running out of time. Can you just conclude, please?
Yeah, I'll just conclude with this case.
Thank you so much.
So, so just to conclude with this case, she received a CDK4/6 inhibitor, and you can see she responded very nicely initially between December 2019 and March 2020. Unfortunately, by May 2020, she had progressed in her liver, and the question was, what were we going to do? Because she had a progression-free survival of 6 months, and as I said, she's got a PIK3CA mutation and NTRK fusion. So at that point, we actually decided to give her entrectinib. It was available on a special access program. And just to show you the results, we gave her entrectinib, and you can see she's achieved a very nice response by July 2020. You can see her PET-CT by September, actually, 2020 was almost a complete response with a very nice drop in her tumor markers to almost normalizing, which we never saw with a CDK4/6 inhibitor. So I'll stop here, and thank you very much for giving me the opportunity.
Thank you so much, ma'am. We'll move on to our next talk. Our next speaker is Dr. Shyam Aggarwal. He's a senior consultant at Department of Medical Oncology at Sir Gangaram Hospital, New Delhi. And he'll be talking on the topic emerging concepts in molecular biology of breast cancer. So with your permission, I will, I will share your slides.
So thank you, Kashish, and thank you, Purvish, to give me this opportunity to cover a few, maybe, relatively newer aspects in the molecular biology of breast cancer. So I think Dr. Shaheenah has laid a pretty nice, background for what I'm going to say. So let us see the next slide. So when Dr. Purvish asked me to, speak on emerging concepts, so I thought I'll cover 10 new things. So I've listed 8 here, and there are a few more which I've not listed, but I'll just, say those in those many words in the end. So let's go one by one. ESR1 mutation, hormone sensitive and nuclear medicine, PIK3C testing, AKT testing, HER2 new mutation, PARP and immunotherapy, PARP and HRR and HRD, and HER2 new positive. So I've divided the slides, a lot of slides, I'll skip them, but then the idea is to give you a glimpse of what is happening in various fields like ER positive, TNBC, and HER2 new positive breast cancer. So next slide. So I think this is one area where people are working on CTCs and cfDNA in ER positive breast cancer. So can I have the next slide? So, this is a publication in Cell where they said that if there are clusters of CTCs, well, these patients don't do that well than as compared to patients who have no clusters. So, so this is basically to look at the CTC clusters and develop them in the wells in vitro and see the response. So this is one area. I think some people are working on it in India, but I think this work can be taken forward. Next slide. The other thing which we understand is the emergence of ESR1 mutation in ER-positive breast cancer. So I think this we all know that as patients are exposed to AI, they have ESR1 mutation, and there's a trial which I came across which I'll show. So I think I have a few slides which I've copied from some of the talks which I heard on video, etc. So you will see the pictures of the speakers also. Can I have the next slide? So this is PADA-1 trial design, in which in first-line MBC HR-positive patients were treated with AI and palbociclib. So I think that profiling, which is what Shaheenah was mentioning about, that every 2 months, if you do a cfDNA analysis and pick up ERCA1 mutation, so you can see the rising ESR1 mutation, and there is no concomitant progressive disease. And then you either give them the same treatment or you switch to fulvestrant. Next slide. So if you do this profiling, and you can clearly see that patients who are ESR1 mutated, in spite of having no progressive disease, when you stick onto the original treatment, they don't do well than as compared to patients who are put on fulvestrant. So therefore, there's a role of dynamic and profiling of cfDNA in patients who are being treated with AI and a CDK4/6 inhibitor. Next slide. So, this is another thing which is reported a couple of years ago. That is the role of, nuclear medicine, F18 fluoroestradiol, because we're all looking for markers as to who are the patients who are going to do well with the endocrine therapy. So if you have a low FDG, and if you have, along with a high, and compare it with the FDG PET, so patients who have low FDG, they tend to do the best. And low FDG and high FES will even do better. I mean, they do better than as compared to if you have low FES. So I think nuclear medicine has a role. If somebody wants to take it forward, you can always develop that as a marker for predicting response to endocrine therapy vis-a-vis FDG and vis-a-vis FES. Next slide. So switching to the PARP and BRCA and HRD. So I think there's a lot of stuff happening in that direction. 7 to 8% of breast cancer patients are germline BRCA positive. 3% of all tumors are somatic BRCA mutation positive. And if you look at TNBC, 18% are germline BRCA1 positive. So I think TNBC is a subgroup where we need to focus. Next. So again, coming to TNBC with BRCA positivity, where patients are being treated with PARP inhibitors. So under the pressure of PARP inhibition, you tend to have development of different profile, in which you can have immune profile, PD-L1 positivity, or you can go through the PI3K pathway, or you can go through RAS-MEK pathway, which could be responsible for resistance. And people are working on this. And the next slide will show you that. So if you see here, after 1 month of olaparib, so there is intense immune infiltrate where you could be using a PD-L1 drug or a PD-1 drug to boost the response to the PARP inhibitor. Next slide. And that is what is seen here in these in vitro studies, that patients, when they are combined PARP inhibitor, either with a MEK, which is for the RAS, or you combine with PD-L1, you can achieve a better outcome. Next, please. And there are clinical trials which are going on to that effect. So, selumetinib with olaparib in RAS-activated tumors will give you a better outcome than as compared to olaparib alone. So, this is what is happening. This is what people are doing. Next, please. You can see here patients who have the immune cell, population's density maximum, they get a CR than as compared to patients where this immune cell activation is little. So I think this is another area of work. When you're treating patients with PARP inhibitor, you can do the biopsy to find out what is the immune infiltrate and what are the kind of cells, whether they are dendritic cells or macrophages or myeloid cells, etc., etc. Next, please. So this is, this is a slide which I've taken from a video where, durvalumab in the Mediola study was combined with olaparib. And, you see, you initially only give olaparib and you're, waiting for the immune cells to get activated, and then your durvalumab comes in. And you can see in HR these TNBC cases, 58% patients can show an overall response. And even in HR positive cases, you can see 69% response. So there is a run-in phase for olaparib, followed by the induction or introduction of durvalumab or the PD-1 drug. Next, please. So, this is another interesting slide where at the moment people have been focusing on BRCA1 and BRCA2. But if you look at BRCA like in ovarian cancer, it is not only determined by BRCA1, BRCA2, but also with the HRR genes, which are 16, 17 in number, like PALB2, ATM, and so on, as you know. But not only that, let me tell you that there are another 50 genes which are DNA damaging genes. So if you were to look at HRD, so HRD could be because of the BRCA1, it could be because of the HRR genes, or it could be because of additional DNA damaging genes, DDR genes. So, the point is to look at the efficacy of these drugs, olaparib or velparib along with cisplatinum in these subgroups of people. And there is very little work. If you were to look at the literature, you don't have, number of patients in TNBC, how many are HRR positive, how many are HRD positive. So this is an area of research which people can adopt. Next, please. And you can see, BRCA-like, you can see these are not BRCA1-2 patients, they are BRCA-like because of maybe the HRR genes. And you can see the overall survival benefit and the PFS benefit in BRCA-like population in the metastatic setting. Next, please. So similarly, you see talazoparib, you can see the efficacy of these drugs in other genes like PALB2 and other, HRR genes. Next, please. Not only germline, but also somatic. So, yeah, so Olympia trial, I think, was read out by Dr. Andrew Tutt, and there was a success for olaparib in adjuvant setting. And today only ASCO has given the guidance for using olaparib in the adjuvant setting for BRCA1-2. Next. So, but the next study, which is the ABCSG study, is not only looking at BRCA1-2, but also looking at high HRD score in the adjuvant setting when you combine olaparib with carboplatinum. So therefore, there's a lot of science which is related to HRR and HRD, which we must, keep our eyes on. And if somebody can do research, kindly do that. Next, please. So this is another important pathway which Dr. Shaheenah covered. That is the PIK3C and AKT pathway in TNBC. We know the PIK3C is the SOLAR-1 study, the alpelisib, but then the TNBC is also becoming so very important because of the AKT drugs which are available, which is an important pathway. So there are several slides. I will just skip those slides because 35% of TNBC harbor this PIK3C in the TNBC setting. Next slide. Okay, so you see in the TNBC, PIK3C is mutated in 20% and amplified in 51%. So that remains a very, very important target, not only in HR positive, but also in TNBC setting. Can you skip 6-7 slides, and then I'll go to the last slide in this section. Yeah, next slide, please. Next. There's one summary slide. I'll just show that. Next. Yeah. So there are two drugs. Next slide, please. Yeah. So these are the two drugs, as you see, ipatercept and the capivasertib, when combined with paclitaxel in metastatic TNBC. So this is the total population, and this is the population with PIK3C AKT altered, and you can see the p-values being in favor of the trial drug along with the chemotherapy. So I think you need to keep track of the AKTI and the PIK3C pathway in TNBC setting also, because it is going to emerge as a target. Next, please. So HER2 new mutations was mentioned by Dr. Shaheenah. 7 to 8% are there in MBC in ER positive or HR positive breast cancer. So next slide. So 2% have there in primary breast cancer, but 7 to 8% will be acquiring resistance when they are subjected to endocrine therapy. So I think next slide. So I'll just, the idea is to use a drug like neratinib along with fulvestrant, as you see here, and trastuzumab. I think the slide was shown by Dr. Shaheenah that it works. So the idea is to look for HER2 new mutation so as to use an anti-HER2 new therapy. Next, please. So, this was the study from the Summit study where neratinib and fulvestrant and trastuzumab was used in patients with HER2 new mutation breast cancer. Next, please. In ER positive setting. And I think there's a 50% or nearly 46% overall response rate. Next, please. So I think we'll skip these slides. Next, please. Yeah, so I think this was already covered. So we must be aware of HER2 new mutations in the setting of ER-positive breast cancer who are being treated with endocrine therapy. Next. So this is another area of PIK3C inhibition in ER-positive cases. So there's a new thing which has emerged, which is the multiple PIK3CA targeting. Next, please. So with a specific target, which is the alpha PIK3C inhibitor. So you see multiple PIK3CA mutation were detected in 26.4% instead of a single mutation. So the idea is there are multiple mutants. So therefore, if you block it, you may get a better outcome. Next slide. And that was the hypothesis which was shown in vitro, that when you do the the inhibition of tumors with multiple PIK3CA mutation, you tend to get a little better change in the in vitro PAKT levels. Next slide. But when it was done in the humans, it has actually not shown that kind of a benefit. But the idea is to understand that there are two categories of patients with PIK3C. They are single mutation versus multiple mutations, and the behavior of the tumor may be different. So that was the idea of showing this data. Next slide. So next slide, please. So something about the HER2 new positive breast cancer. So I think people are trying to, profile or do stratification of all HER2 new positive patients because of the heterogeneity amongst this. And this is a study with the 80 gene blueprint from the affinity trial subset of population. And they were trying to see which patient population derives benefit from pertuzumab in the affinity trial. Next, please. So with this, they showed that HER2 positive or HR negative. So this is the distribution as per that particular blueprint study, and the results showed. Next slide. That there was a trend towards greater pertuzumab benefit in patients with blueprint HER2 single activated tumor, and the hazard ratio was 0.56. And these patients who are luminal single or basal single, they don't tend to benefit in the affinity study. So people are trying to subgroup the HER2 new positive patients by doing these kind of gene profiling by this blueprint study. Next. So again, the mRNA studies, the DNA copy number, methylation, and DNA mutations, and tumor infiltrating lymphocytes. So, I mean, this is what people are trying to identify, which are the subgroups who are going to benefit most or maximum from the HER2 new therapy. A couple of slides, and then I'll finish. Next, please. So this is again the HER2 diagnostic, combined prognostic score based on TILs, based on PAM40, expression of 55 genes obtained from patients in short-HER phase 3 study, and they've been able to segregate these subgroups. So, people are trying to do these kind of studies or modeling of subgroups. Next, please. So I think this is what I've said already. Next slide. So this was another study where they were trying to look at, overall HER2 positive, but then they were HER2 positive in the circulating tumor cells and trying to look at patients who could benefit from lapatinib or not. So these are detailed, descriptive studies, which one has to go into the details of this, but that kind of work is ongoing. Next slide, I'll skip and I'll, I think, finish this. Next slide, please. I'll not go into the details of this. Next. So that would be, I think, the last slide. Next slide. So finally, before I conclude, I think I just wanted to include some slides on HER2 new low breast cancer. So which is an emerging data because of the efficacy of deruxtecan trastuzumab. So I think one should also look into that data as well. So finally, to conclude, dynamic ctDNA analysis is an emerging theme to understand what is the mechanism of resistance in ER positive or ER negative or triple negative patients, so as to change your treatment or modify your treatment or adopt your treatment depending upon the emerging problem. So not only PIK3C is important in ER positive, but also in TNBC. I think there is a lot to learn in BRCA1, BRCA2 positive, and HRR and HRD in patients with TNBC. HER2 new mutations, I think we must understand now because we have data on newer drugs, and we should look for ER positive patients, whether they're developing HER2 new mutations. and HER2 new positivity, people are wanting to further classify. So I think with this, I close here and thank Purvish for this opportunity, because I did learn and pick up a few new things from whatever I learned in the last 1 week. Thank you.
So we've received a question in the chat box. So with your permission, can I read that question?
Sure, absolutely.
Yeah, so we've received a question from Dr. Pallavi. How frequently we should do CT DNA?
So that's a very, very gray area. So, I think it depends on the biology of cancer which you are treating, because as you know, ER positive patients may be an indolent disease. So as you saw in the PADA study, they did every 2 months or every 3 months. But I think you are guided by the evolution of cancer in a given patient, because triple negative is going to be a little rapid evolution. So I think it depends on what kind of patient you have, given the preceding history. There's no consensus on this, because this is evolving science. But if somebody has the money, sure, every 2 months, 3 months, but it is guided by the behavior and the biology of cancer which you're treating.
Thank you so much, sir. Dr. Parikh, with your permission, we'll move on to the next session.
Yes, please go ahead.
So thank you so much, Shyam, sir. We request you to please join our panel. So we'll move on to the panel discussion. The topic is hereditary breast cancer. How do I decide and what do I do? Our moderator is Dr. Ajay Bapna, Director and HOD Medical Oncology at Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. His panelists are Dr. Shyam Aggarwal, Medical Oncologist from New Delhi, Dr. Prashant Mehta, Medical Oncologist from New Delhi, Dr. P.K. Jayachandran, Medical Oncologist from Chennai, Dr. Saurabh Kumar Mishra, Medical Oncologist from Bhubaneswar, Dr. Shevanti Limai, Medical Oncologist from Mumbai, Dr. Vinayak Maka, Medical Oncologist from Bangalore, and Dr. Akhil Kapoor, Medical Oncologist from Varanasi. Over to you, Ajay sir.
Yeah, thank you very much, Dr. Parikh, for giving me the opportunity for this panel discussion on this wonderful meeting. Can I have the next slide? Okay, so the panelists have already been introduced to you, so we will directly move to the panel discussion. So my first question is that what are the key elements for minimum adequate cancer family history? So can I ask Dr. Akhil to elaborate? And for your convenience, I'll project a slide and you can take help of that slide. Next slide, please. Dr. Akhil, please.
Yes, sir. So definitely, while working at TMS Mumbai, I got the exposure of the genetic clinic, where we were drawing the diagrams for the proper documentation. So definitely, you need to document the first degree relatives, the second degree relatives, and also, as mentioned in the slides, both document from the maternal and paternal side, because we sometimes miss either the maternal side or sometimes miss the paternal side. That should not be done. And also recognize the age at the diagnosis in the family members. For example, if a patient has his mother also diagnosed breast cancer at the age of 40 years, it is definitely a completely different connotation as compared to age at diagnosis at 70 years. Similarly, consanguineous marriage, which are much common in some communities, that should be highlighted. And apart from that, other cancers history, like example, ovarian cancer, then pancreatic cancer, which are prostate cancer, any association. So these should be looked into.
Ethnicity also, Dr. Akhil?
So, sir, in most of our patients, we have found that for BRCA 1 and 2 in our own cancer genetic clinic, we have found some specific mutations have specific areas. For example, the patients who are coming from Nagpur and Jhalabad area, these have some specific mutations, and they are repeatedly the same similar mutation as being found in the patients coming from that area.
And I presume Sindhis and Parsis also.
Yes, sir. Completely agree.
Yeah. Thank you, Dr. Sir. Can I have next slide, please? So next, after the knowing the family history, this is very important to know the red flags or what are the indication for referral to the genetic counseling. So I request Dr. Vinayak to elaborate on this topic, and for your convenience, I am again projecting a slide. Dr. Vinayak.
Yes, sir. I think slides are very helpful. So I think one thing is that we have to have that suspicion as soon as we see a patient. With the newer, the diagnostic tests are very much covered. So any patients who are very young and two malignancies either synchronous or metachronous. Sometimes there will be, I think we are making religiously. Our third line is family history. First is performance.
Yes, absolutely.
Third line is the family history. So if anyone says malignancy both side, like our Akil said, both side 3 generation, if you have anyone, we draw the graph and we'll put it on page. And if you have any indicator that it requires testing, we would refer to genetic counselor. We have in-house genetic counselors, so we refer them. And one thing I have seen that we cannot leave the whole matter to them. The context and everything has to be discussed with them also. We have to be part of that decision making.
Yes, very good point. So can I have next slide, please? So now I move to my first case. She is a 26-year-old female, unmarried, software engineer by profession, complained of lump left breast for only 1 week duration. A true-cut biopsy showed invasive papillary carcinoma. So she was treated with surgery and stage was P-T2P-N1M0 triple negative breast cancer. Regarding the family history, mother had triple negative breast cancer in 2008, and just now her mother completed treatment for high-grade serous adenocarcinoma for ovary. She has 2 siblings, one elder sister 28-year-old and the brother 22-year-old. Next slide, please. So Dr. Sevanthi, can you tell us that how will you proceed with this patient now?
So this is sir, I'll just request you to go back to the previous slide.
Yeah.
So it's a young patient, and she's already had the surgery. That's mostly the case in such scenarios. Obviously, this patient needs to be worked up for a germline finding, mainly young age, family history, all of that positive. You have to proceed with therapy, but at the same time, you cannot leave behind the fact that this patient may have a germline mutation and may require addressing that in the next step of your treatment.
Yeah, thank you, Dr. Sevanthi. Can I have next slide, please?
Surgery, so start the next steps of the
So,
surgery.
Dr. Saurabh, can you elaborate that what kind of pre-test counseling you will do to this patient or the index case?
So, sir, for this patient, most important thing is that before I proceed with a test, I have to tell her what I'm expecting out of the test and what it means for her if we detect it and if we do not detect it. More importantly, what does the test mean for her as well as for her other siblings? That also needs to be done. Also, we need to tell her that the test, it may come positive or it may come negative. So what are the implications of that? That has also to be discussed with her. If it comes positive, if it is positive, then whether it's a pathogenic or whether it is a variant of unknown significance, that has also to be discussed with her. So with all of these, before we proceed with this test, we have to take the patient into confidence that why
Absolutely.
this test is being done.
Yes.
And if at all something comes up, we are there to explain it to, and the genetic counseling, it has to be there after that also.
Yeah, so to tell you, all of you, that she came to us on the last day of her mother's chemotherapy to us, and the family was, you believe me, was devastated.
Correct.
Yeah, next slide, please. So this was the report as mentioned by Dr. Sevanthi, and she was found to have BRCA1, which was classified as pathogenic. Next slide, please. And high penetrance gene, as you all know, that the BRCA1, and it confers a 5-fold increase relative risk of developing the breast cancer. And the pathogenic variant in these genes causes autosomal dominant cancer syndromes, and the risk that can be estimated through pedigree analysis. So, you know, if through drawing a pedigree, you can come to know the exact status of these patients. Next slide, please. And from this graph, you can very well see that the BRCA1 has been put in the high penetrance gene in comparison to the other genes, which signifies the clinical significance also of this pathogenic variant. Next slide, please. So, Dr. Jayachandran, so we have the report in our hand. So, what is the kind of post-test counseling now you will do to this patient?
So, first of all, we have to inform the patient about the test report, which is an pathogenic variant, and we have to try explaining about the therapeutic implications and the prophylactic implications and other things like testing the other family members. So the therapeutic implications of this mutation would be like of recent, what are the options available for this breast cancer, current breast cancer treatment, whether there have been additional agent used when there's a BRCA mutation or not. And prophylactically in this patient, we need to explain about the risk of getting other cancers when there's a BRCA1 mutation, like the other breast is there. So she can have other breast cancer, and also there can be a possibility of getting an ovarian cancer. The risk also has to be explained. Being she's unmarried, we should give her the options of chemo prevention, or we should also tell her when should she have the prophylactic treatments.
Absolutely.
Explain.
Yeah.
The other thing is, next thing is what is risk for the family and how to counsel the family for that's next cycle which will come up.
So do you believe that ideally we should sit with the family entire?
I think it must be the patient first. The patient, each and every person must be separately counseled. Probably I don't think so. Maybe Indian culture is different, but ideally it's not the family rather than the patient per se.
Yeah, I totally agree, Dr. Jayachandran. Next slide, please. So this is the NCCN guideline 2021, mentioned whatever we have discussed, that the breast cancer risk and management, the evidence of increased risk very strong with predisposition to triple negative disease, and absolute risk in these patients is more than 80%. Next slide, please. And risk of ovarian cancer is 36 to 56%. So this was the Indian data which was recently published in Journal of Clinical Oncology, but this was about BRCA1 mutation in ovarian cancer. And the conclusion was that there is a high prevalence of pathogenic or likely pathogenic germline BRCA mutation in Indian patients of ovarian cancer. And I'm pretty sure that in the breast also the result will not be very different. Next slide, please. So, Dr. Prashant, are you there?
Yes, sir, I'm there, sir.
Yeah. So, what is the appropriate? I did not actually in the first slide mention that what kind of surgery she underwent. So, what is the appropriate surgical management of the index malignancy for women with newly diagnosed non-metastatic breast cancer who have been found to be BRCA1 BRCA2 mutation as this case?
So you asked me a very difficult question. I think all the surgical
general knowledge, I mean, general knowledge.
All the surgical oncologists feel that it is not any contraindication, not even a relative contraindication for breast conservation. So, but I remember that Devita, the textbook mentions it as a relative contraindication. Not sure of the newer edition, but I personally am not very much in favor of breast conservation for a mutated patient, for a patient with a mutated cancer. But yes, the surgical oncologists are very strong in their opinions, and it is not considered a contraindication.
Okay.
Yeah.
So, can I have next slide, please?
Yeah.
So, the new information is that the germline BRCA status should not preclude a patient with newly diagnosed breast cancer otherwise eligible for BCT from receiving BCT.
Yeah, this is old information and every surgical oncologist says so. And this guideline has come about because of strong opinions from surgical people. Because medical oncologists, they're not driving the surgical decisions.
Yeah, absolutely.
They're not.
So
but look, if we apply some common sense, it does not seem the right thing to do.
And the surgical management of the index malignancy in BRCA1 BRCA1/2 mutation carrier should be discussed, and considering the increased risk of contralateral breast cancer and possible increased risk of ipsilateral new breast cancer compared with the non-carrier. So it is basically a relative contraindication, not the absolute contraindication.
That's what the textbook also says, like relative contraindication.
Yeah. So next slide, please. And the following factors should be considered for assessing the risk of contralateral breast cancer and role of risk-reducing mastectomy in BRCA1 BRCA2 mutation carrier. Means, I mean, not all patients are eligible for it. First of all, we need to consider the age of diagnosis, the family history of breast cancer, overall prognosis from this or the other cancers like ovarian, and the ability of patient to undergo appropriate breast surveillance like MRI, comorbidities, and the life expectancy. If the index case fulfill all these features, then probably she can be put on the follow-up only. Next slide, please. So, Dr. Shyam, now your turn. Your backdrop is so beautiful with the flowers. So, what are the options for patients who do not wish to go for contralateral risk-reducing mastectomy for these patients?
Right. So, as I think,
as you believe that most of the patient will definitely refuse.
Right. So basically, it depends on the age of the patient, and it depends whether they have completed their families and all that or not. Because this particular patient whom you showed was 26 years old.
Yes, software engineer.
So so the practical thing would be perhaps to think of surveillance. Of course, is required, in which a patient has to undergo an MRI compulsorily, every year, so that you can pick up a disease early. Number one, chemo prevention is would also be in order, so as to reduce their risk of developing the breast cancer in the opposite breast. If the patient is a little older, then of course you have the data for surgical oophorectomy, so as to reduce their risk. So these are the 3 points, and of
Yes,
course,
absolutely agree.
most patients will refuse the contralateral mastectomy.
Yeah, next slide, please. So there is a information that the BRCA1/2 mutation carrier who do not wish to go for bilateral mastectomy should undergo high-risk breast screening for remaining breast tissue with annual mammogram and MRI, as mentioned by Dr. Shyam Aggarwal just now. Next slide, please. So, Dr. Shyam, can you tell us further that what is the role of radiotherapy, though you are not a radiation oncologist, as mentioned by Dr. Prashant when it was asked about the surgical, question. So, what is the means the feeling that what is the role of RT in this patient, because she preferred to undergo the breast conservation therapy.
Right. So I think the management of breast cancer, whether it is germline positive or negative, is not going to be affected. So it remains the same, depending upon the size of the tumor and the nodal involvement,
Yes.
and whether BCS has been done or the total surgery has been done.
Yeah.
So I don't think that BRCA influences the role of radiation.
Next slide, please. So for women with breast cancer who are treated with breast conservation therapy or with mastectomy, for whom post-mastectomy radiotherapy is considered, our radiotherapy should not be withheld because of mutation status alone. But remember that except for the mutation in TP53, where the radiotherapy is contraindicated. So two information have come up so far, that these patients should not be devoid of breast conservation therapy, and they should not be deprived of getting the radiotherapy as well. Next slide, please. So, Dr. Prashant, now can you tell us that now this is your question. So, what is the role of neoadjuvant, adjuvant, platinum chemotherapy in women who have a BRCA1, BRCA2 mutation breast cancer? Both neoadjuvant.
So in the neoadjuvant, probably there is some role, probably increasing the rate of pathological CRs, and probably from the Japan-Kinto study, I remember. So it's in BRCA mutated and women who have familial history of breast cancer in that subset. So there is a role, but same is with nab-paclitaxel also, but not sure of the role. It is not a certain role. It is something which is there.
Yeah, so just now we are not comfortable using the platinum in neoadjuvant or adjuvant setting. Can I have next slide, please? So, for germline BRCA mutation carrier with breast cancer treated with neoadjuvant or adjuvant therapy, currently data really do not support whether it is a KLGB trial or the 6-part G2 as mentioned by Dr. Prashant, that they do not support the routine addition of platinum to anthracycline and taxane-based chemotherapy, which is the backbone for managing the triple negative breast cancer just now. And while single agent platinum has demonstrated activity in neoadjuvant setting, there are no data yet comparing it with the standard chemotherapy. So next slide, please. So there has come a role of maintenance cisplatin, and this ECOG ECRIN EA1131 trial, which was just now published, it has clearly shown that the platinum agents do not improve outcome in patient with basal subtype triple negative breast cancer post neoadjuvant chemotherapy, and are associated with more severe toxicity when compared with capecitabine, which was the basis of CREATE-X trial. And the participants had lower than the expected 3-year invasive disease-free survival, regardless of the study treatment, highlighting the need for better therapies in high-risk population. So the conclusion has come out that in the neoadjuvant, adjuvant, and maintenance, these patients really don't do well with the addition of the cisplatin. Next slide, please. So Dr. Jayachandran, can you tell us that what is the role of PARP inhibitor in women who have BRCA1, BRCA2 mutation or selected moderate penetrance mutation in the non-metastatic setting? So you can, restrict your answer to the BRCA1, BRCA2 mutation.
Yeah, I think the ASCO has given us the answer for this. The trial, which is a major trial, the PARP into olaparib, which has been shown to be given and beneficial in terms of invasive disease-free survival and distant disease-free survival. With the use of 1 year of olaparib in BRCA1 and BRCA2 mutated patients, with the recent ASCO, probably in some time we'll get a guideline revision for all patients. We might need to do BRCA testing using it as an guidelines.
Yeah.
In metastatic setting, we have a couple of BRCA inhibitors in BRCA1, PARP inhibitors in BRCA1 and BRCA2 mutated patients.
Yeah. So this information was just now. Yeah, this information was just now shared by Dr. Shyam Aggarwal. Next slide, please. So the ASCO has currently included the inclusion of PARP inhibitors for 1 year in these kind of population based on the this study Olympia trial, which was this month only. This was published in NEJM. So this has become an integral part of now the adjuvant maintenance setting in BRCA1, BRCA2 mutated triple negative breast cancer with very high level of evidence. Next slide, please. So the conclusion of Olympia trial was that among patients with high risk HER2 negative early breast cancer and germline BRCA1, BRCA2 pathogenic or likely pathogenic variant, adjuvant olaparib after completion of local treatment and neoadjuvant or adjuvant chemotherapy was associated with significantly longer survival free of invasive or distant free than was placebo. So this has become standard of care and we can use it from Monday. Next slide, please. So the prognosis was prognosis wise, it is same for the BRCA1, BRCA2 mutation carrier or the non-carriers, and approximately 70% of the breast cancer that developed in BRCA1 carriers are triple negative breast cancer, and whereas approximately 75% in BRCA2 carriers are ER positive cancers. Next slide, please. So Dr. Saurabh, can you tell me that what will be your approach to the other two unaffected siblings?
So sir, basically now that we have the proband who was detected to have a BRCA mutation, which is pathogenic and deleterious, and since it's a autosomal dominant inheritance, we do understand that it may have been inherited from any of the parents, and there is a 50% chance that other siblings do have a risk of this mutation in them. So based on that pre-test counseling, I should also advise them to undergo this BRCA. Since we have now a BRCA mutation in such a patient, I would rather do a BRCA testing in the other siblings, and based on that, I would go for the risk. I would counsel them further.
Yeah, that sounds absolutely okay. Next slide, please. So this was all about the first case. A young girl, software engineer, has a lot of dreams, but unfortunately, she has deleterious mutation. So now we move to case number 2, 47-year-old female premenopausal, presented with 1.2 centimeter palpable mass, family history, a significant for paternal aunt diagnosed with postmenopausal ER positive breast cancer, and her paternal grandmother with ovarian cancer. Biopsy showed moderately differentiated infiltrating duct carcinoma. ISC ER was 99%, PCR was 55%, and HER2 was negative. She has two sisters aged 45 and 41, who are unaffected. Next slide, please. So this was the germline mutation test for her. She was found to be having the ATM pathogenic variant. Next slide, please. So in this graph, again, you can see that the ATM has been put quite lower down, and this will come under the category of moderate penetrance or low penetrance in comparison to the case which we have just now discussed, BRCA1, which was high penetrance. Next slide, please. And we need to analyze these reports of genetic tests very carefully. The positive tests are pathogenic or deleterious or likely pathogenic variant identified. Increased surveillance is required in these patients. Risk reducing strategies is required in these patients, and pre-symptomatic testing for the family, as mentioned by Dr. Saurabh, and the family planning counseling should be done in all these patients who are found to be having a likely pathogenic variant. In comparison to the patient who are negative, they can be followed up or they can be counseled as any other normal population. Next slide, please. So, Dr. Sevanthi, what is your understanding about this case which has a moderate penetrance genes vis-a-vis high penetrance genes, which was the our first case?
Yes, sir. So in the high penetrance genes, there is a higher likelihood of the pathogenesis of breast cancer in that patient, specifically ovarian cancer as well. I personally, having dealt with large proportions of hereditary breast cancer.
Oh, really?
Have had the I've had the attitude of trying to counsel the patient for corrective surgery. I wouldn't say that in the same way for lower penetrance genes, where the risks are lower. Having said that, it does warrant careful monitoring if you're going with watchful monitoring of that patient. And in this case specifically, where the rates of breast cancer could be lower, but still significant enough.
Absolutely.
Significant enough. So we one cannot just sit tight, because it's for that patient, it could be that incident. And the range is wide. 20 to 60% of breast cancers could happen as a result of ATM. So not 80%, but I think for that one patient, one cancer, and it does the deal. So I still follow my patients very carefully, even for moderate penetrance or low penetrance. If it is a very, very low penetrance mutation or alteration, that's when the rules are relaxed a little bit.
Yeah, wonderful. Yeah, next slide, please. So this is the definition of moderate penetrance genes, that between rare high penetrance genes and common SNPs lies a group of so-called moderate penetrance genes, and moderate penetrance genes alteration pathogenic variant that confer 2 to 5-fold increased risk, as opposed to high penetrance alteration like we have seen in BRCA1, BRCA2, and PALB2 and T53. So these are the genes in which the pathogenic variants are found in 1% of the general population. And in comparison to, you remember the first slide which I have shown, that these patients cannot usually be identified through pedigree analysis. So this is the difference between the high penetrance and the moderate penetrance. Next slide, please. And you can see the whole list of these germline pathogenic variant, and ATM is also lying on the 4th number. Next slide, please. So, Dr. Vinayak, can you tell us that what are the second cancer risk in the contralateral or the ipsilateral breast cancer in this patient who has a moderate penetrance gene?
The exact number, I think, will be difficult to quote, but the risk is is increased for sure. I think you have to.
Okay, so can I have next slide, please? So the understanding is that the ATM variants are not associated with an increased contralateral breast cancer risk even after the radiation therapy, as we have seen in the first case, and there are no data indicating that a woman with moderate penetrance pathogenic variant are at increased risk for ipsilateral as well. And the consideration for contralateral preventive mastectomy may be reasonable in such women only if they are young and with a significant family history of breast cancer. So this is our understanding about the contralateral and the ipsilateral breast cancer recurrence. Next slide, please. And for the surgical management, women with ATM pathogenic variant should not be precluded for considering the breast conservation therapy also. Next slide, please. So, Dr. Akhil, can you tell us what is the risk of ovarian cancer in this patient who has moderate penetrance?
I don't think, sir, this patient will be having a risk of ovarian cancer, to my best of my understanding.
Yeah, because in the percentage of the patient with the high penetrance is very high. So in comparison to, next slide, please. So in comparison to that, the ATM has not been definitely associated with an increased risk of ovarian cancer. 2 studies, though, are there comparing pathogenic variant in patients with ovarian cancer with the public database control reported 2.2 to 2.8 fold increased risk only, which is not really very high. Next slide, please. So, Dr. Shyam, again, your number. What is the role of PARP inhibitor, as you mentioned in your presentation about the high penetrance? So, what will be the role of PARP inhibitor in these kind of patients?
Right. So, so currently the approval is only for BRCA1 and BRCA2. And I think the data is evolving at this point in time. But I think even with PALB2 is coming closer, but I don't think there is approval at this point in time for ATM at least. So I think we need to do some more work in this direction before one can prescribe these drugs.
Okay, thank you. Next slide, please. So a small study is there only. TBC C048 has suggested the olaparib is highly active in patient with MBC and not in non-metastatic breast cancer and germline PALB2 alteration, but not in women with CHEK2 or ATM. So absolutely there is no indication of using PARP inhibitor in moderate penetrance gene patients. Next slide, please. Dr. Prashant, is there any role of risk reducing salpingo-oophorectomy or screening for cancer pancreas in these patients?
So you're talking of ATM mutation patient?
ATM. Focused.
So no definite role of RRSO, I believe.
Okay. Next slide, please. So the premenopausal risk-reducing salpingo-oophorectomy is unlikely to benefit these patients, and deferring surgery until after menopause is recommended for these patients, and benefit of screening for pancreas is not established in these patients. So I'm comparing the high penetrance versus moderate penetrance so that our understanding becomes a little bit clear. Next slide, please. Dr. Jayachandra, any instructions for her two unaffected sisters?
So they can be advised routine screenings, and also they can be advised genetic counseling, which can be going through the pre-test counseling. I think even though there's a low penetrance, I think we should try to do a genetic counseling and then genetic testing.
Yeah. Next slide, please. So the management of unaffected relatives of women with moderate penetrance pathogenic variant should be referred to genetic counseling and the pre-symptomatic staging, and unaffected women have average lifetime risk exceeding 20% are therefore candidate for enhanced surveillance with MRI in addition to mammography. The current recommendation for these patients is to begin such surveillance at the age of 40 years, although there may be benefit of starting younger, especially if there is a significant family history. In the absence of prospective validation, it would be unwise to forego enhanced surveillance on the basis of an adjusted absolute risk under 20%, particularly in the presence of family history. Next slide, please. So this is the chart. Next slide, please. So Dr. Shyam and Dr. Sevanti, you work in a very high-end, hospitals. So what is the knowledge level of your kind of patients about, all these, what we have discussed just now?
So some of the patients will come with prior knowledge, but a lot of the patients will not have knowledge of the specifics. I mean, some of these patients will ask whether this is running in the family. Some of the patients are very aggressive. They want both the breasts chopped off, and the others are very conservative. And they, even if you approach them about bilateral mastectomy, and just in the discussion will just totally shy away from the conversation. So I think it's very variable. It is less than the expected amount, because I think hereditary breast cancers are still not that common, and the community angle, specific community angle is not that predominantly present everywhere.
So don't they come with the Time magazine having the Angelina on this front page?
I've had one patient like that, an artist me with all that, and was totally ready to get bilateral mastectomies without a BRCA test result back yet.
Yeah, I understand.
These do happen. I think it happens to all of us. But
yeah, Dr. Shyam, what is your view on this?
Yeah, I think what Dr. Sevanti said was quite appropriate. But I think more important than that, it is the medical oncologist's perspective which has changed because of the availability of a suitable agent to treat these patients, whether in the adjuvant setting or in the metastatic setting, whether it is an ovarian cancer or it is a breast cancer. So earlier, patients perhaps were not knowing, but now we have no choice but to tell them that we are doing this test at least for your treatment. And then if it comes positive, then you can decide and go to a genetic counselor whether your sisters or siblings and relatives should do that test, because then it becomes a very, very wide issue. So I think the perspective of the doctor has changed. which has become mandatory now in day-to-day practice for breast cancer and ovarian cancer patients to undergo this test.
Yeah, I totally agree with you. And with the, the recent publications, our understanding definitely have become more and more clear now. Next slide, please. So to summarize, the multi-gene panel testing identifies pathogenic variant in a substantial fraction of women with breast cancer. Cancer risk and management approaches are well defined for women with pathogenic variant in high penetrance cancer syndrome genes. For genes that confer more modest degree of risk, best practices are still less clear. And in general, the treatment of women with breast cancer and pathogenic variant is in moderate penetrance gene should proceed as treatment for women without such alteration. And some genes are associated with sufficient ovarian cancer or pancreas cancer risk to warrant intervention, but not all. And unaffected family members should undergo carrier genetic counseling by a knowledgeable provider to be informed of the most up-to-date risk figures and the recommendation for the management. He should not confuse the patient any further. And in most situations, the breast cancer risk for unaffected women will not warrant serious consideration of RRM, although MRI surveillance will often be appropriate, and risk-reducing salpingophorectomy will need to be considered for only some pathogenic variant. Next slide, please. And for this patient, the treatment received was that this patient elected to undergo wide local excision and sentinel lymph node biopsy. She was staged as PT1C N0N0. Her 21 signature gene recurrence score was 16, and she elected for adjuvant anti-estrogen treatment alone, and she was referred for adjuvant radiotherapy also. Next slide, please. So in the end, I would like to quote a tweet from Dr. Rajiv Sarin that let's all gang up against the root genes. Families with inherited cancer risk can be helped in so many ways if their genetic risk is known in time. The hereditary cancers can be prevented, detected earlier, and treated for cure with timely access to genetic counseling and the genetic testing. And he has formed a kind of gang which is called the Gene Solver Gang. Thank you very much for your kind attention to all the panelists who have participated very actively in this panel discussion. And back to organizers, please.
Thank you, sir.
Thank you so much, Ajay sir. We'll now move on to the last part of the session. Our speaker is Dr. Saurabh Kumar Bhattacharya, who is the head of Department Clinical Cytogenetics, National Reference Laboratory at Dr. Lal Path Labs Limited. And his topic will be HER2 testing by FISH, the Lal Path Lab experience. Over to you, sir. Dr. Saurabh, you'll have to unmute your mic, sir.
Yeah, thank you for the introduction, and thank you, Dr. Purvish, for inviting me here to talk in this eminent forum. One second, just. Yeah, so I'll be discussing about HER2 testing by FISH, and I'll be discussing about our own experience in our laboratory here in New Delhi. And first, I'll talk about. Yeah. First, I'll talk about the HER2, or which is also called as ERBB2 gene, is a gene that is amplified and its protein is overexpressed in approximately 15% to 20% of breast cancers. Cancers that overexpress HER2 can be treated with monoclonal antibodies that target the HER2 protein on the surface of breast cancer cells. Trastuzumab, also known by the trade name Herceptin, was the first drug approved by the US FDA in 1998 for treating HER2 positive metastatic breast cancers. And since that time, the treatment of HER2 positive breast cancer has evolved, with more treatment occurring in the non-adjuvant setting before the primary tumor is resected. And multiple other HER2 targeted therapies have also been introduced. And we know that HER2 is a prognostic marker that indicates more aggressive tumors with a high risk of metastasis. Patients with HER2 positive tumors have a decreased overall survival compared to patients with HER2 negative or non-amplified tumors. And of course, those tumors are associated with worse clinical outcome in absence of therapy with drugs like Herceptin. And HER2 is a predictive marker as well, in that it predicts likelihood of responding to HER2 targeted therapies. And this is a picture which shows that how IC is helping us to understand the HER2 status. And we can see the negative, how it looks, and the 1+ score, how it looks in the right side. And the bottom left side equivocal looks like this, and the positive 3+ HER2 is showing a high stain, the high nuclear stain. This is the slides which I'm not going to discuss everything in what 2018 ASCO and CAP guidelines have told us about optimal scoring and interpretation of the HER2 fish, because it is very helpful. And so far we were following 2013 guidelines, and in 2013 guidelines the major problem was due to equivocal score in fish, where we were ending up in using some other probes, and finally we are in a dilemma of giving out the reports with equivocal results, which is not helping patients and the doctors. When 2018 guideline has come, it is helping us to understand that whether our tumors are actually positive or it is negative. And if it is lying in between group 2, and if it is lying between group 2, 3 or 4, then what we should do to understand whether it is a positive or negative tumor. So immunohistochemistry is very important here. The final in situ hybridization results for group 2, 3, and 4 is therefore determined by integrated review of the ISC and ISH results. If rescoring of the ISH slide is required, an independent observer must rescore the ISH slides or in situ hybridization slide within the areas of invasive tumor that demonstrate equivocal staining. The final interpretation is determined by the final in situ hybridization results as shown in this diagram. So finally, what we get is a group 1 positive, group 2 negative, and group 3 can be positive depending on the ISC rescoring and the blind scoring of the in situ hybridization slide. Group 4 can be negative, and group 5 is clearly negative as mentioned earlier. So this is what I wanted to show, that how many samples we have processed in these 2 years, financial years. So in 2019, we have processed almost 730 samples, and in 2020, we have processed 785 samples. And in this current year, till first quarter, we have almost crossed 600+ samples. So this year is going to be a boom for us because we have processed so many samples. And in this way, we can see that how many we have got a positive. So almost equal in 2019 and 20, 232 in 2019 and 233 in 2020, we got positive, and negatives were 442 and 488 respectively. And these are the repeat samples which we have repeated due to some problems in the block. When we don't find any tumor in the block, if there is a scanty tissue, and if there is a very less tumor content in the block, we had to repeat sometime. So I've segregated our results according to the groups suggested by 2018 ASCO. And you can see the group 1 has shown the clear positive Clear positive reports are gone out from our lab as 229. And in 2020, those were 217. But surprisingly, in group 2, we didn't find any sample in this particular group. In group 3, we have found 2 samples in 2020, group 4, 3 in 2019, and 2020, there are 14 samples. Whereas in group 5, which were clear negative, those were 442 and 488, as I have mentioned in earlier slide. So when we compare our results with ISC in our same lab, we have found that we have compared 137 samples altogether for in situ hybridization and ISC. So there were 50 samples which were negative in both, equivocal ISC in 67 samples, and there were positive clear cut in 20 samples in ISC we have found. So what are the special scenarios during HER2 testing in fish? I'm going to discuss these 3 important points. One is heterogeneity, the tumor heterogeneity, and then polysomy versus co-amplification, which is very interesting to know that there is very, very important discussions going on in lots of forums, even in ASCO, that there are polysomies, whether we have to consider polysomies or whether there is a co-amplification and what to do next. And the third category will be uncommon hybridization patterns. I'll discuss in few slides. So what is tumor heterogeneity? So there are multiple tumor cells which shows negative signals, whereas there are few cells with very high copy number of HER2. So these are the mixed population of the cells with the normal and the positive cells, and this is very uncommon. And I have seen, I have not seen it so often in our lab because this is very rare phenomena. But whenever we get this type of abnormality or this kind of slides, it is sometimes very difficult to conclude the results. And the same way in this slide, you can see that there are positive cells here, stained cells here, whereas there are negative cells or normal cells here, and it is difficult to interpret those slides. And same way here, these are again the example of tumor heterogeneity, the positive stained cells here and the negative ones here. And this is again, this type of tumor results in ISC positive, whereas in situ hybridization is negative. If this particular sample is sent for Oncotype DS risk assessment test, it will come out to be as positive. So again, there is a dilemma and what to do, because HER2 is negative in this type of samples, whereas ISC will be positive. Now I'm going to discuss about, there are a few sample of uncommon fish hybridization patterns which we encounter in our lab. And you can see here, these green signals are corresponding to the centromere or the control signals in a HER2, in a chromosome 17, whereas the orange or the red signals are for HER2, particularly HER2 or ERBB2 gene. So you can see here, there are multiple green signals visualized here, but there are very few red or orange signals we can see in different cells. So these are actually centromere 17 amplification. We do not call it as positive sample because there are only centromeres are amplifying, but there are no HER2 amplification. So we don't call it as positive. This particular pattern is very common and seen in about 1% of tumor, probably due to deletion of one allele of chromosome 17, but we don't know unless we do microarray on this sample, because you can see there are, in few cells, there is only one green signals, like here, like this cell, but there are multiple HER2 signals. So here it is very difficult to conclude the ratio of the HER2 versus centromeric 17 or the control probe. And there it is being suggested that microarray is helpful to understand the pathogenicity. This is an example of HER2 probe deletion, either 2 copies or single copies, copy loss. So that happens, but it is exceedingly rare. But I have seen it in my lab here, that there are multiple copies lost here. So there is no orange signals here, but there are only green signals. So these are actually now the centromere signals present, but there is no HER2 signals. So sometimes we don't know whether a single allele of HER2 is lost, or both the alleles are lost for HER2 gene. So again, microarray is always helpful here to understand that what is happening in this particular sample. And this is a clear-cut positive case. I would say there is a HER2 amplification. There are multiple orange signals, and there are 2 or more green signals here. So we can call it as a positive HER2 samples. So these pictures are taken on 2 individual filters in our FISH microscope or a fluorescent microscope, where HER2 at the left and the centromeric 17 at the right shows exact copies complement to each other and concluded as polysomy. But we were actually wrong, and we were proven wrong by Shelley Gunn et al. This paper has been published in 2009 in Modern Pathology. So where they studied 100 samples with array CGH for HER2 status in breast cancers, and what they have revealed was this chromosome, particular chromosome 17, which is the chromosome which carrying a HER2 gene, doesn't show any polysomy in microarray or array CGH. So what they say is, if you do CGH microarray, you won't find any polysomy chromosome 17, and in breast cancer, at least it is non-existing. Out of the 100 samples they ran, CGH, and none of them were showing polysomy 17. So what we used to refer polysomy was actually not polysomy, which probably result of co-amplification, where centromere is also co-amplifying with the HER2 gene. So this is a probable answer that we still don't know exactly, but it should not be referred to as polysomy anymore. So how to improve HER2 testing accuracy? What points we consider in our laboratory to improve HER2 testing? So these are the points what I would say. Small tumors. So small tumors are always good. I'll explain one by one all the points. Small tumors, there are more defined denominator. Tumors with nucleus score 1 are invariably negative. Tumors with Ki67 less than 5%, almost always negative. Specific histologic features are consisting of metaplastic tumors, which are spindle cells or squamous, are always negative. Non-mammary tumors, almost always negative, but there are certain cases where they were positive as well. Invasive micropapillary carcinoma, where 50% of the time it is showing positive, and the squamous phenotype, almost always positive. So what I was referring for the small tumors and the large tumors, the major problem with the large tumors are, the labs, whenever they are getting a tumor cells, they have to make a multiple blocks out of those. And the biggest problem of making multiple blocks are sometimes there are few tumor cells which are consisting in 2 or 3 blocks, whereas other blocks which are made may not be carrying the tumor cells, and which are ending up in the in the no tumors in the blocks and ending up in a repeat blocks. And those are the biggest dilemma when we do practice in a lab. But small tumors are always good, because small tumors usually we go for 1 or 2 blocks, and those are very good to test. And we can take out the slides and do the test with the good accuracy, and we can get our results. So these are the routine HER2 QA program which we have implemented at our institution right now. Invasive tumor verified on always verified on H&E slide. Parallel ISC study was performed on almost every sample. This is actually routinely we do, because sometimes we don't know, because most of the time the blocks are coming directly to us for a fish, and ISC is done in somewhere else, some other lab or some other hospitals. But we do not have a clear picture of ISC every time. So if possible, we try to do ISC again in our lab and see that how it has been correlated. H&E and ISC slides reviewed at time of fish testing, and then fish reading performed by a cytogeneticist, and then finally by pathologist. Pathologist purposefully blinded to previous results, because the pathologist should not know that how cytogeneticist has scored the slides, and then we conclude finally that what is an average, and then take out the results. Before reporting, results are compared and discrepancies are resolved, and monthly or quarterly metrics are evaluated. Corrective actions were also taken if necessary. So to conclude my talk here, 2018 focus update moved closer to performing ISC and FISH on all tumors. That is very important, because we have got rid of equivocal FISH results, which was a big nightmare for us. 2018 guidelines will swing the pendulum in the negative results direction. It is very obvious, because negative results may not be negative every time, because we have to go back and see ISC status and then rescore the slides. Although new 2018 guidelines has helped us to get rid of equivocal results, but tumor heterogeneity is still a problem, as I mentioned in my slide. Correlation with ISC and tumor histopathology and performing metrics is mandatory in order to improve HER2 testing accuracy. So I end up my talk here. Thank you very much.
Thank you so much, Dr. Saurabh. With that, I would now like to introduce Dr. Ratima Kohli to please give the conclusion and the vote of thanks. Over to you, ma'am.
Thanks a lot, Kashish. I would like to thank each of the panelists who have been helping us guiding the things. Before I conclude, I just want to inform each one of us that we at Dr. Lal Path Labs are doing all the PDL1 testing, which includes Ventana platform, SP142 clone, SP263 clone, as well as we are doing PDL1 DACO 223. Along with that, at this point of time, while we are performing the BRCA testing, both hereditary and somatic testing, so we are confirming that by MLPA. We are at this point of time having coupons at a very discounted pricing for the hereditary BRCA testing. So if anybody wants to avail for their patients, we are there to support all the clinicians for that. Now I would like to thank Dr. Shaheenah and Dr. Shyam for giving us an information about the molecular markers, Dr. Ajay Bapna for moderating the session and the panel discussion in hereditary breast cancer. All the panelists, Dr. Prashant and Dr. Parikh, thanks a lot for helping us and guiding us through the breast cancer profiling. Over to Dr. Purvish, sir.
Thank you very much, Ratima. I think this has been a fantastic experience. We
Yes,
had
sir.
two wonderful speakers who gave the latest. ESCO has just gotten over a few weeks ago, and we still have the value of their insights from that data. And I think the best part was the wonderful panel discussion moderated by Dr. Ajay Bapna. All the panelists were doing a fantastic job. And finally, we heard the fish and how HER2 is refined and how Lal Path Lab is able to give the most accurate data today. So I think overall our audience has learned and benefited immensely from this breast cancer webinar. And I thank everybody, all the speakers, all the faculty, all the participants, and Lal Path Lab for sponsoring this. Thank you very much.
Thank you, sir.
Thanks a lot. Thanks a lot, everyone. Yeah.
Thank you, sir.
Thank you.